Hi, this is Junaid, neurocritical care stroke and epilepsy specialist. Today we're going to talk about advanced practice providers, non-physician providers. Those who are outside of the United States may not know what advanced practice providers are, so we're going to define them and then move forward. However, I think it's still interesting for you to understand what the US market is going through and how the future of healthcare can look in different countries as well. So, we talked about work-life balance and lifestyle considerations, financial consideration, and work type mix, and how physicians can have different types of work type mix. Now we're moving about future of healthcare, in which we're going to talk about artificial intelligence, virtual care, and advanced practice providers. These are significant, important areas in which, when you are deciding your choice of subspecialty or specialty, you need to take these into consideration. So, who are advanced practice providers, or basically defining non-physician providers? So the word provider is colloquially used to, and as an umbrella term, to have these APRNs and PAs, which we're going to talk about. But provider in general means physicians and all these other sort of available entities in which they have prescription power, that they can have management power over patients. Now, advanced practice registered nurse, APRNs, are the bulk of the overall advanced practice providers in the United States. These are registered nurses who have a higher education that they have done. Some of them have master's degrees, some of them have even doctorate degrees, and some of them have just more clinical work, and they are doing practically like a mini-residency under physicians to learn how to take care of patients, and then go back and then ability to work themselves into a provider role from a nursing role. And there are multiple different ways in which people do address them. The most common of them is nurse practitioner. The second one are sort of some similar to them, in which they have specified goals during their training. One of them is clearly CRNAs, which are registered nurses who are anesthetists. Then there are midwives, and there are clinical nurse specialists, and then there's of course the psychiatric mental health nurse practitioners, PMHNP. So these are different roles in which nurse practitioners do. The second one is physician assistants. Physician assistants were not nurses and then go into it. They do have a bachelor's degree and then afterwards go for a 2-year school and then become physician assistants. Their roles are less defined, and it is very state by state, and they're truly, in terms of providing care, are under the complete medical license, as compared to APRNs, which can potentially work independently of a physician in certain cases in certain states. So before I get into it, and some people are going to be very, especially if it's a US market and you're from the US, there are definitely some biases that are going on. And I'm going to just address them right now, because that's very important, what my personal bias is, because that's very, very important to understand where I come from. And that also depends on what my subspecialty and specialty is, because the way I take care of patients, the way my needs are, it is extremely important that how it reflects. So therefore, you need to understand where your subspecialty and specialty meets in terms of APP utilization or competition, where you are in that particular market. So I'm a neurologist, and I'm basically in neurocritical care, stroke, and epilepsy. Those are the 3 categories that I function in. Neurologists in general have significant physician shortage, right? I mean, there's a physician shortage in general, but neurologists is crucially significant shortage. So generally what I have to do care of patients, higher patient load burdens, and therefore extra set of hands is extremely important. For me, I've seen is that most of my patients require anxiety, depression, all these kind of things. So we do definitely need psychiatry help in a lot of neurology patients. And getting a psychiatry help is extremely hard. So I'm grateful that some of the PHNPs, those psychiatry, mental health, nurse practitioner specialists, they came out to help these patients as well. Secondly, both the situations that I exist in, one of them is acute care, where you have time is brain. So either in neurocritical care or stroke, we need extra set of hands, because time is brain, and you need some person to help through the process to decrease the latency of care itself. So that's fantastic to have these kind of support systems, for me especially. And on the second hand, when there is chronic care, which is chronic stroke prevention is concerned, which is more, in my terms, more algorithmic approach, in more defined in these situations, the chronic care piece and coordination of care piece, to be honest with you, nurse practitioners do a better job than I do. Same patient, if the person has epilepsy, is coming in for a routine follow-up. Is there any side effects of medications? Do you have any new seizures? Getting the routine lab work done, etc. at the end of the day, those kind of things, they can do pretty good. And to be honest with you, I feel like they do a fantastic job, and might as well let them do some of this work, because that takes the cognitive burden and the physical burden off of me, so that I can take care of the more complex sort of situations in terms of patient population is concerned. So as I said, this is my personal bias, and it comes from my particular subspecialty, right? Because I am a neurocritical care, epilepsy, and stroke person. There are different places in which these is not completely accurate, or this is not completely applicable. So therefore, your particular stance may be different, but I wanted to make sure that my bias is there first. So I believe that they are an integral portion of neurological care, and I also believe that they will be a crucial part of healthcare in the future, especially considering the advent of artificial intelligence, because more and more algorithmic approaches will be, clinical decision support systems are going to come in, also with virtual care, where the APRNs can be at the bedside and physicians can be on the website. So therefore, you will have a transition of proper care in which geographical redistribution of physician work force can be done in areas of the most need, and APRNs can be helpful as far as delivering that care right at the bedside as well. So that's my bias, and I wanted to make sure. Another important thing from where my bias comes from is that the people that I've worked with, I have worked with some fantastic nurse practitioners, and I can sing songs about their, empathy, their work ethic, etc. So I personally worked with very excellent people, and maybe that is the case, and you may have a different experience. But at the end of the day, I genuinely feel that they do provide very good care. And more importantly, they are ability to learn more and more, and therefore perform better and better. And they'll, at least the people that I've worked with, generally have great empathy, and patients loved it, because then I can also trust them. And one of the things that are confusing, and sort of we're going to get to it as well, but they do not like to be called doctors, at least in the inpatient setting. They understand their limitations most of the time. They do go up to one level and then say, okay, Dr. Kalia, this is where I need you to answer these questions. These are, calls that needs to be made. And generally speaking, it's not that they cannot make the call. I mean, to be honest with you, they have seen me making the call for years and years, but the question still remains that they do hold the line. And the reason behind it is that they, at least the people that I've worked with, they understand the risk and benefit. And at a certain point in time, some things are going to come from a physician's mouth, which is more important in terms of both sometimes compliance, family satisfaction, or in general, medical legal perspective as well. So all in all, I think most NPs are honorable in that regard, that at least I've worked with have been fantastic. And they do want to be respected as clinicians, right? I mean, they're not there to just write notes, right? I mean, these are not medical scribes. These are actual providers. So I do also give them decision-making power, and that's why they enjoy it. And I think that's very important, that they do feel that they're part of the care team as well. These are my biases, and some people may disagree and some people may not, but at the end of the day, this is what my experience been, and this is what your experience can be very, very different. So I want to lay it out first when I start this video. Now, one of the things that we have to understand is that what I talked about, the burnout problem. We have to understand that there's lack of physicians, there's significant amount of physician moral injury, and then there's a significant burden of coordination of care that is going on. The stupid EHRs, which do not at all are intelligent. There's a lot of clicking. For one order, you have to make 17 clicks, to be honest with you. This is ridiculous. So all this kind of workload that is being increased to physicians. There's a recent study that more and more physicians are thinking of leaving. As a matter of fact, APRNs and nurses are not different. They are also burned out. But at the end of the day, when we are looking at this healthcare system as a whole, I think that nurse practitioners are going to be very important in terms of bridging that gap of supply and demand. As you can see, it is increasing as we move forward, and this will be very, very important. And for me personally, as I said, that if smaller decisions like the patient is constipated in the ICU, yeah, somebody can move on, right? I do have to go through meeting after meeting discussing like large intracerebral hemorrhages and talking about bad outcomes in the neuro ICU. I do get compassion fatigue, and so decision fatigue, compassion fatigue, and then stupid documentation fatigue is there. And rather than victim shaming, I think APRNs can be a real way to support physicians in terms of combating moral injury. Now the question really is that, do nurse practitioners, so the question here is that where do nurse practitioners are most effective? I told you acute care, in which there's definitely more hands, period. It doesn't matter like what your capabilities are, to be honest with you. At that point in time, you just sometimes just need more hands. I mean, you're coding a patient, you need more hands. But more importantly, the burden of coordination of care is there. In those situations, they shine a lot. And the burden of coordination of care is highest in primary care areas. And then ensuring continuity of care, order entry, reconciling of discrepancies, etc. So that kind of work, that is extremely very, very important. We do not think that this is unimportant work. This is work that will prevent a future stroke. Those kind of stuff, nurse practitioners, when they are taking care of these primary care patients, they are doing it, and that's extremely important. I'm very grateful for your time. In the next lecture, we're going to talk about rapid growth of nurse practitioner workforce, and then we're going to move on different topics as we move along. Thank you. If you save a life, it is as if you saved the life of mankind. Please make sure you like, comment, share, and subscribe to my YouTube channel and my newsletter. If you want to get in touch with me, the best way is to go through Twitter or via LinkedIn. Also make sure you follow the Academy website for regular updates. Thank you so much.